have some cases. We'll go through them. Dr. Brisbane's joining us as well, and yeah, we'll take it from here. Thanks.
Nice meeting you, man.
All right, let's see. All right, so we've got.
To be at UCLA. Thank you very much. It's been great.
You hear me? Yes. Pre-test probability makes a huge difference in test performance. Have you noticed in those studies where the sensitivity of PSMA?
I can't hear you very well, Kareem.
I was saying pre-test probability makes a huge difference in terms of test performance. The PSMA studies where 40% sensitivity was seen was in what population?
Yeah, that 40% sensitivity is in patients who were selected for surgery. So patients who had, metastatic or nodal disease that didn't elect surgery were, kind of tossed out. So the true sensitivity is, I am sure, higher than 40% for detection of metastatic disease. But in patients who underwent surgery who had a negative PSMA PET, clearly the sensitivity is lower. I think that's basically what it is. All right, so I've got a bunch of cases, and we have some time, so let's kind of go through these. So first guy is a 76-year-old man, had unfavorable intermediate risk cancer, was T1C initially, PSA 16, Gleason 3+4. He underwent SBRT in January 2017, had a nadir PSA of 0.8. Then his PSA started to rise, PSA 3.2, had a negative MRI. PSA continued to increase, now 4.3. He underwent a biopsy that was negative. And then he underwent a PSMA PET scan. So, Phil, what do you see here?
So we have a PSMA PET, multiple axial images. There's that focus of activity sort of in the center of the prostate.
Yep, basically. Yeah, go ahead.
You wonder sometimes, sometimes could it be urine, sometimes is it actual? When it's midline, you sort of question, you want to sort of interrogate that a little further.
Yeah, so he had a negative, biopsy, as I said, but then we found this very high SUV, so obviously we were very concerned about this. There was actually, at least according to Jeremy, even a second, perhaps smaller little satellite area here. So Dr. Marks, one of my colleagues at UCLA, has been doing a lot of PET-targeted biopsies, so he went ahead and biopsied both of these lesions, as shown here, lesion 1, lesion 2, and as you can see, they came back largely positive. So certainly, I think this is a case where PSMA PET can really help detect the sites of radio recurrent disease. There are definitely false positives, but I think that this is a technique and something we're going to be seeing. We are seeing more of a lot of radiation recurrences that historically we couldn't really detect. So this is I think a really interesting case.
So Rob, a question I have: would you have gotten a PSMA PET earlier rather than waiting for nadir +2? And I'd love to get Sean's perspective.
Yeah, I mean, it was early in our prospective trial, so I don't think he was a candidate for it at that time, and we didn't have the technology to do the biopsy. So yeah, I would have. Now the question is how early, because radiation recurrences are nadir +2, nadir +1.5. Clearly, more patients are having recurrences that we're waiting longer to detect, and then the outcomes of patients who have radiation recurrent disease are worse because PSA is so high.
Well, the problem is that it takes about 3 years for the prostate to really go negative in terms of biopsies after. So you don't want to do it too early, because then if you do it too early, let's say you do a biopsy at 18 months, you're guaranteeing a positive biopsy, and then you're going to expose a potentially cured patient to treatment side effects. My question about this case is, it looks like these lesions were very close to the urethra. Did they actually do urethral sparing in their SBRT, or was it, because to me, you got to be really careful. A lot of people are like, oh, with SBRT, we got to spare the prostatic urethra. Well, the prostatic urethra has cancer right next to it. So that case, to me, looks like someone who overspared the prostatic urethra. Because we know that SBRT never really fails in the prostate.
No, radiation never fails. That's what I've been told. So this is actually a pretty simple case, and this is apropos of one of the cases that Phil showed. It's a man with Gleason 9 cancer, had a biochemical recurrence with a PSA of 0.55. You can see here he's got this lesion in his rib, very high SUV max. Everything else was negative. What would you guys do?
I mean, it's so tempting to want to call this a metastatic lesion, but there's that series, I think it was the British Journal of Urology, that talked about like 50 cases with a solitary focus of activity in the rib, and all of them were not prostate cancer. I think this one, given the fact that it's really intense, sort of makes you really want to call it. But then you look at the CT, and I'm being told it was negative, so I would probably just ignore this.
That's interesting. I think, I've got another case or two kind of about this whole the rib issue. So this guy, of course, had very high-risk disease. He clearly had a recurrence. SUV was high, and so, we thought, at least our radiologists thought, very high probability of prostate cancer. Yes, you could biopsy it, but we went ahead and treated it with SBRT, and he's had a good and durable PSA response.
But remember, I'm never wrong.
You're never wrong.
By the way, can I bring up one thing?
Yeah, sure.
So to me, I mean, even if you had one rib lesion, local treatment is still going to benefit that patient. There's lots of studies in radiation oncology with people who probably
salvage to the prostate.
No, I mean, I would radiate the prostate, even in people who with very high PSAs who probably have metastatic disease. There's a survival benefit to radiating the prostate with low burden. This is clearly really low burden. This isn't a conventional imaging rib.
Right.
This is a PSMA positive single rib. If this person doesn't get local treatment, you're doing them a disservice.
I don't know whether he got local treatment or not, so I can't answer that. But I can tell you his PSA has been 0 since he had this single site radiated, so he's done very well.
Great job.
But this is something we're seeing much more commonly, and again, this really does get to what Phil's saying. So this is a patient who had he had a biochemical recurrence, but we see this all the time in newly diagnosed high-risk patients, where they've got what looks like a rib lesion. The SUV is 2.6. In this case, there was something sclerotic area here in the bone. So what about this one, Phil?
This one's tricky. The SUV max is a lot lower. There is something in the rib, but it's more peripherally sclerotic, which tells me it's not as aggressive. Again, I would probably lean towards not calling this a metastatic lesion.
Right, and we also didn't believe that this was a metastatic lesion. It was a lucent lesion with a sclerotic rim, as you said, and so we thought that this was probably an endochondroma, something like that. And we see so many of these, kind of faint rib uptake. And, I have to really talk to the nuclear med guys a lot. There are those who I really trust who have seen thousands of these, and there are others who kind of overread and overcall things. So I think this is a challenge that we're seeing with PSMA PET. And so basically, I put this down here. This is from Jeremy Calais. Excluding men for potentially curative local treatment based on an indeterminate suspicion of solitary PSMA PET rib metastasis, not justified. Low isolated uptake in somebody who otherwise has M0 disease, consider negative, or do follow-up imaging. All right, so here's another case. We've actually seen quite a few of these over the years. So 72-year-old man, PSA 8.3, underwent prostatectomy in 2011, had salvage RT in 2013, PSA started to rise again, we got a PSMA PET, and he actually has this very low intensity signal in his lung, as shown here. So a solitary a lung lesion. This is a tough one because the SUV max is quite low.
So, when I see something like this, the one thing I always want to do is I want to see prior images. So if this patient had a CT chest a year ago, all right, is this new? Is it growing? What's the deal there? And also, you also have to remember that even though it stands for PSMA, everything isn't prostate specific. There are other things that could have uptake in as well. So you worry, is this a primary lung lesion? In the end, I think you have to biopsy and prove.
Wayne, would you biopsy this guy?
In the lung?
In the lung, yeah.
Yeah, I think I would, just to make sure that it's true.
Yeah, we've seen a lot of these solitary lung lesions, and they've actually done quite well. They often are true oligometastatic sites of disease. So he actually did have a biopsy confirmed to be metastatic adenocarcinoma of the prostate. He actually had this resected, and he's been free of disease ever since. Next case. So a couple of cases of very similar looking cases, very different outcomes. So I thought they would be worth showing. So 63-year-old man, Gleason 8. He had surgery, then had salvage radiation in 2011. Initially he responded, but then PSMA started to rise to 1.6. And he had PSMA PET. As you can see here, he's got a left perirectal lymph node, 5 millimeters, SUV max 7.7. So how would you treat this? Would you treat it? And if so, how?
So this is probably 11 years ago. We didn't treat the pelvic lymph nodes very much. So this is probably just someone who got prostatic phosphoradiation.
Probably, yeah.
So I would probably treat that lymph node. I would also give a higher dose to that pelvic lymph node, but I wouldn't ignore the rest of the pelvis. I would probably give a low dose like which you talked about in the lecture, like 50.4 gray to the pelvis, 66 gray to that pelvic lymph node, which is, I'd say, easy to do. And I would also recommend that because he's lymph node positive, I would always refer him to our medical oncologist, Nancy Dawson, who's awesome, and she would probably do doublet therapy. But I'd be curious to see what other doctors would do with
Right,
this.
so there are two questions, whether to give, to radiate this, to radiate the rest of the pelvis, the rest of the lymph nodes, and to whether or not to use ADT. I think the evidence for ADT at being synergistic is pretty strong, but not all patients want it. This guy, I actually think, opted out of getting androgen deprivation therapy. He did have this single site radiated. I don't know if he had the rest of his pelvis radiated, and he's actually had an undetectable PSA for 6 years now. So he's the isolated site of oligometastatic disease who did well. Here's a patient, looks exactly the same. So 77-year-old man, a patient of mine, underwent surgery in 2013. Pre-op PSA was 21. He had pretty bad disease. He actually had adjuvant radiation without ADT. PSA started to rise, was 0.2 in 2021. So Wayne, what would you do in this patient?
I would probably do what we had talked about, doing radiation to that lymph node and then consideration of ADT.
Anybody differ with that? So he actually enrolled in our clinical trial of radio-guided surgery. So basically to resect this, he looked like the perfect case, slowly rising PSA many years after surgery, initial surgery and radiation, and just a single site of disease. So we took him to surgery. We gave him PSMA technetium the day before surgery, took him to the OR, used a gamma probe to detect metastatic sites. And what we found actually at the time of surgery was interesting. We found this node pretty easily. We actually found additional nodes around it that were clearly hot. And I started working up my way upwards, basically towards the retroperitoneum, and I kept detecting signal. At that point, we didn't know, is that real, is it not real? But I basically said, I'm not going to help this guy, and we ended the surgery. And sure enough, he ended up having 5 nodes right in this site, 2 nodes in another site, and then what I expected is that a few months later, sure enough, he popped up with all these retroperitoneal nodes. So I think this points out how little we still know about oligometastatic disease, and where are we just seeing the tip of the iceberg versus the whole thing. Now, whether radiation or surgery makes a difference in the setting, I don't know, but I don't think radiation would have helped this guy either. So just cases to show, cases where it works and cases where it doesn't work.